Hey guys, welcome, and we're so glad to have you join us for today's mini review. As you guys are coming in, don't be afraid, hop in that chat box, let us know where you're joining us from today, or give a shout out to your school. Okay, so again, as you guys are coming in, joining us, hop in that chat, let us know where you're joining us from, or give a shout out to your school. While you guys are doing that, my name is Ashley. Everybody calls me AG. I am the Social Marketing Director and a faculty expert here at Hurst Review Services. I'm a nurse. I've been a nurse for 15 years, and I've been with Hurst Review for 11 years, and I love what we do because our goal is to make sure that you guys are ready to take and pass your NCLEX on the very first attempt. Now, if you're joining us and you've already taken the NCLEX before and you've been unsuccessful, don't panic, okay? Because this is what we do. We don't just help first-time test-taking students. We help all test takers to be able to take and pass the NCLEX. So we love, again, what we do. All right, guys, we're going to go ahead, jump in, get started. But again, don't be afraid as you come in. Let us know where you're joining us from. We'd like to give you a shout out, okay? Or you can give a shout out to your school. All right, the very first thing that we want to talk about is let's just talk about what the NGN looks like, okay? Because we know that the NGN has been here for a while now, and we want to make sure that we understand what we're walking into. So you're going to have 5 hours max testing time. You may not need 5 hours to take your test, but you've got 5 hours just in case you do. Your minimum question count is going to be 85, and the maximum question count will be 150. Now, all this means is that no matter how you are performing, you're going to get at least 85 questions. Okay, your test is going to go to at least 85. But if you have not shown the computer with enough certainty, if you have either already passed all of the client need categories, or if you have fallen too far below in one or more of the categories, your tests will continue. And your test can go on until 150 questions. Now, yes, that also means that your test can stop at any number in between those two numbers, but everybody will see at least 85 questions. All right, let's talk a little bit about Hurst Review because now I want you guys to understand who we are and what we do as a company. The first thing that I want you to know about us is that we are a company of nurses for nurses. So our founder is a nurse, our entire curriculum team, all nurses. All of our faculty are nurses, but we've also got one or more nurses in places like sales, marketing, social media, and customer support, just to give you that nursing support that we know that you all need. So we're a company of nurses and we are completely for you. All right, let's talk a little bit about data because I want everybody to also understand, like, how are we able to help you? One of the things that I love is that when students start asking the question, what did you do when you got ready to take the NCLEX and what did you use to prep? We love when we get tagged in those kind of conversations. And so 9 out of every 10 students that takes the Hurst Review turns around and recommends the Hurst Review to another person. And that word of mouth recommendation, that's the one that you're looking for. Okay, yeah, it's great that we stand here and we talk about Hurst Review. That's wonderful. But what you're really looking for is somebody that took the Hurst Review to talk about the Hurst Review. Well, guess what? I took the Hurst Review when I was in nursing school, and I passed my NCLEX on my very first attempt. So I'm not just telling you from the standpoint that I work for Hurst Review. I'm telling you as a previous Hurst Review student that this product really does exactly what it says it does. You know, the other thing is that we used to have a 98% first-time test taker pass rate, but we've recalculated our pass rate since this data was put out. And so I love the fact now that even with the changes in the NGN and COVID and all of those things that happened, our pass rate not only stayed the same, it went up. Our first-time test taker pass rate is now 99.8% for first-time test-taking students. And I love the fact that what we do has consistently worked. What do I mean by that? Okay, well, guys, we're not new. We are not a new NCLEX review company. In fact, we've been around for 37 plus years. And so over these 30 years that we've been in existence, we have been able to help our students pass their NCLEX. That's what I meant when I said I was a Hurst Review student. Okay, I've been a nurse for 15 years, so that means that I took my NCLEX before then. It worked then. It still works now. And I love the fact that we're able to help students no matter when you've gone to nursing school and when you're prepping to take whatever NCLEX and version of that you are. Okay, now let's talk a little bit more about the NCLEX because there's some information that we want you to know before you take it. This is not our information. This is information directly from the NCSBN, the people that write the test. They let us know through data that if you don't pass the NCLEX on your first attempt, then your chances of passing the NCLEX have automatically declined. Now, I know that that sounds horrible. It sounds really negative, but that does not mean that you can't pass. It just means that this is proof as to why people always focus on let's take this one time and not have to take it again. Because the data will show you that the pass rates dramatically decline when somebody has to take the exam more than one time. Okay, so if you find yourself in that boat where you've already taken and you were unsuccessful, we have to change the way that you prep. So that way you have the highest chance possible of passing the NCLEX. All right, well, why does this even happen? Because people start going into the NCLEX looking at it as an extension of nursing school. And that's not what it is. It is a safety test in its entirety. And the goal of the test is not just to see if you can meet another requirement. It is to protect the public from any nurse who would be deemed as unsafe. Hey, did you take a test in nursing school that was trying to deem if you were unsafe? No. Hey, well, there might have been one, but the goal of that test was not really just to see if you were unsafe. It was still to see if you could meet a requirement. And that might have been your dosage calculations exam. But other than that, that was it. They weren't giving you those tests to see if you were safe or not. They were giving you those tests to help you meet a requirement and to help them meet a requirement too. The NCLEX people say, we do not care about your requirements because everybody has different ones. They're saying universally, I don't care what nursing school you went to or where you decide to work. I need to know that you are safe and that you can keep people safe and alive. That's the goal of this test. And so if that's the goal, that means that the way that they ask the questions and the way that you answer the questions has to be different than anything you did in nursing school. Okay, because this is different, that means the way that we prep will be different too. And guys, I'm going to show you exactly what that looks like here in just a minute. Well, how do we prep you? Let me show you a sample page out of our student workbook. Every student that takes the Hurst Review receives a student workbook. And guys, I love the workbook because it basically becomes a study guide. This is not a textbook, nor is it written in textbook format. We're not giving you another textbook for it just to collect dust because that's exactly what all your textbooks have been doing. You barely opened them, you barely read them, and even if you did, tell me what you remember out of reading it. You can't. It's impossible. It's too much. It's too much information all at one time. So what we did is we stripped it and we gave you a workbook that you work through. So that way, this becomes again the study guide and you're able to remember what's here a lot easier. As you can see, there are pictures, diagrams, charts and graphs, simple phrases or sentences, blanks and bullet points. And guys, we're going to help you fill in all the blanks that you have in your student pages. So again, once it's all the way filled in, you use it to study. All right, let me now show you exactly what I mean. I'm going to give you some sample lecture, and we're going to use the topic of fluid volume deficit to cover this. Now, I'm going to tell you before we start, there's going to be all kinds of things popping up on your screen. So feel free to take all the notes that you want. You can also ask any question that you want. That's what I'm here for. So the way that you ask a question is you just hop in your chat box or in the comments, and you ask whatever question that you have. And then I'm going to do my very best to answer those questions for you. Now, if you're using the chat box, I'm going to try to answer those questions in real time. If you're using comments, then I may answer your questions offline and go back and get those for you. But I will answer your questions to the best of my ability. Then at the very end of this, we're going to practice some NCLEX style questions together. All right. Let's jump in, and the very first thing that we've got here is let's talk about what fluid volume deficit looks like or means. So you've got some interchangeable words here. Right away, we already know that hypovolemia is an interchangeable word. It means pretty much the same thing. And if somebody is in too big of a deficit or too big of hypovolemia, we just call that shock. So basically, this is your shock lecture. So everything that we talk about here, you can relate to anything that goes on with shock in the body. Now, the easiest way to understand shock is that there is an issue with supply versus demand. I don't have enough supply of oxygen getting to my tissues to meet the demand for cellular metabolism. So something's off, okay? Supply versus demand. Now, one of the things that we need to look at is the causes. Okay, what causes fluid volume deficit? Well, there are a lot of them. And I know in nursing school what you guys did is you spent tons of time talking about all the ways that people lose fluid from their body. But instead of doing that, let's just group them together. Because at the end of the day, if you lose volume from anywhere, you can go into shock. So that's our first cause, a loss of fluid from anywhere. Now, I know that you understand that people can go into shock when they have surgery or trauma. We get that. Okay, but what about the client with an NG tube hooked up to suction and the canister just keeps filling up over and over again? Could they go into shock? Absolutely. Okay, what about a thoracentesis or a paracentesis? Well, they're pulling fluid off the client, so yep, I better worry about shock then too. And then don't forget about things like lots of vomiting or diarrhea or excessive urinary output. Those clients can go into shock too. Instead of spending tons of time and lots of chapters talking about all of those things separately, just put them together and go, whenever the client loses fluid from anywhere, I worry about shock. Good, let's move on. Okay, our next cause is something else that you've always talked about in nursing school too, and you know this one. It is third spacing. Okay, third spacing. Now, here's our definition of what third spacing looks like. This is when fluid is in a place that does you absolutely no good. Okay, question. Hop in your comments or in your chat, and I want you to tell me, where does fluid have to be in order for it to do you good? In order for you to be able to use it, where does that fluid have to be? Okay, let me know in the chat. Okay, well, think about it. If it's third spaced, it's not where it's supposed to be. It means it's going out into the tissues. And I can't use that. So the place where it needed to be was the vascular space, okay, in my vessels. See, if it's in the vascular space, I can circulate that around. But when somebody has third spaced, it goes out. Maybe like into the tissues or even in the form of ascites, where that volume is all out into your abdominal cavity. Now, in the past, what we've done is we've asked students, what is ascites? Like, where is that fluid? And they'll say things like, oh, it's in your stomach. And we're like, no, it's not. That's the organ. Okay, if it's in your stomach would explode. It's got to be somewhere where it can actually expand and stretch. Okay, so it's got to be out in the abdominal cavity. Okay, so when I've got somebody with ascites, I need to measure their abdominal girth all the time, okay, every single day. And the reason why I'm measuring their abdominal girth is not only to see how big can the abdomen get. I'm really worried that the bigger it gets, it's going to start pushing up on your diaphragm, and then you can't breathe. See, that's the nursing thing that I can't forget about. I've got to always make sure that you can breathe. So don't forget about the breathing trouble. Now, guys, just a little bit more about the client that has ascites. And if you don't understand this, don't panic, because if you take the Hurst review, we are going to talk about this in our GI lecture. I typically think about the client that has liver disease if I think about ascites. Okay, and if I look at them, they look like they're in a fluid volume excess, right? Yeah, because they got all of this volume hanging out here in their abdomen, and I can even hear it. Like if I move them, I can hear it moving around. Okay, but you got to think about it. Is the fluid in their abdomen extra fluid? No, it's not additional fluid. It's fluid that leaked. It leaked out of their vascular space and went into their abdominal cavity. So as the abdomen gets bigger, the vascular space gets smaller. This is fluid volume deficit. So don't be surprised if you start seeing your client showing you signs and symptoms of shock. The blood pressure would drop and the pulse and respirations would go up, because this is fluid volume deficit, not excess. Looks a little bit weird. I know it can get a little bit tricky just because of the way that it looks. But again, it's a deficit. All right, our next cause is diseases with polyuria. Okay, guys, let me know in the comments or in the chat, what is a disease process that we talk about in nursing school like 50 million times, where the number one symptom is polyuria? You know it. Diabetes, right? Okay, diabetes. Okay, diabetes is the one that we always talk about, and polyuria is definitely a sign and symptom with that. Okay, well, what in the world goes on when the client has diabetes? What happens in their vascular space? This is a really good time for us to show you an animation. Guys, we use animations all throughout our courses just to show you what things really look like. So that way, if you're a visual learner, you have an idea. Okay, so let's watch this animation with Aunt Marlene to understand polyuria better.
Hello everyone, this is Marlene Hurst, also known as Aunt Marlene. I'll be checking in with you from time to time throughout the course, okay? Well, let's talk about the vascular space in the diabetic. This is a picture of the vascular space. And since we're talking about a diabetic, look at all of the particles. Now, since they are a diabetic, what are the particles? Sugar. Lots of sugar particles everywhere. And anytime there are too many particles in the blood, the kidneys want to help get rid of the particles. But y'all, have you just ever excreted a sugar particle one day? No, you would have remembered that day, wouldn't you? Particles have to come out in volume, in fluid. So the more you try to excrete a sugar particle, or any particle for that matter, it has to come out in volume. That's why the vascular volume starts to come down. Now, we call this process PID. No, it's not pelvic inflammatory disease. I know that's what you were thinking. It's particle-induced diuresis. Now, any particle can cause this, but again, since we are talking about diabetes, we know the particle is glucose.
All right, that's why we said polyuria, think shock first, because that's exactly what can happen when the client experiences polyuria. Okay, so one of the other things I have to keep in mind is my vascular volume. When somebody's vascular volume drops, what should happen to their urinary output? It should go down. Yeah, because that's your body's way of saying, okay, let me try to keep you alive. Hey, you're losing too much vascular volume, so let me hold on to the little bit of volume that you do have left. So I'm not going to void right now. Okay, but the problem is that the client can go from having polyuria to oliguria and then all the way to anuria, where they're not putting out anything at all. And when people start getting oliguric or anuric, you start worrying about renal failure. See, understanding why something happens is the key to passing the NCLEX, because then you don't have to memorize and you don't have to guess. You know, you've got something you know. All right, now let's talk about our next thing that we have is antidiuretic hormone. This is a chemical, sometimes just referred to as ADH. Now, let's talk about what this chemical does. What I really think of when I think about antidiuretic hormone is diabetes insipidus. And when it comes to this, antidiuretic hormone is responsible for making me retain. But specifically, what I'm going to retain here is just water. Okay, H2O only. And the way that I remember that is ADH, H2O. Okay, there's three, right? Three little letters or numbers in their abbreviation. Okay, well, what happens is if we don't have enough ADH, instead of retaining the water, we begin to lose large amounts of water. The client will begin to diurese large amounts of very dilute urine. And if they're losing all of that urine like that, they could definitely go into a fluid volume deficit and, of course, go into shock. That's the number one thing that I'm scared of with this. Okay, now DI, diabetes insipidus. Does that have anything to do with glucose? Yes or no? Let me know in the comments or the chat. Does diabetes insipidus have anything to do with blood sugar? See, the more nervous you get when you take the NCLEX, you start missing stuff. You might see diabetes and go, oh my goodness, insulin, glucose. Okay, but this is not diabetes mellitus, this is diabetes insipidus, and it does not have anything to do with glucose, insulin, or anything like that. All right, now when I see the D in DI, I think diurese, because that's exactly what's going to happen. So that would be a little strategy for you. Anytime you see the D in DI, just think diurese, because that is exactly what the client is going to do. They're going to void. All right, guys, tell me, where in the world do we find ADH? Like, where is it found or stored? Let me know in the comments or the chat. Okay, where do you find it? I'll give you a hint. It's up here somewhere. Your pituitary. Okay, pituitary. And in a real class, like in a live review class, I would ask students, hey, point to your pituitary gland. And they point everywhere except right here. Okay, typically what we tell students is just point in between your eyes, because that is going to be a really big clue as to how do they get to it. And we're going to talk more about that in just a little bit. Okay, but what happens is that people don't walk up to their primary healthcare provider and go, okay, doc, look right here, because that's where they told me to point, right here. I've got a problem in my pituitary. I've got an issue with my ADH. That is not how that works. What happens is ADH problems are usually secondary to some other type of problem. So things like maybe a craniotomy or a head injury, pituitary tumor, sinus surgery, or the big one, the dreaded one, the transsphenoidal hypophysectomy. See, what happens is when you don't know how to say a word, just say it really fast. So that way people don't know that you don't know how to say it. Okay, the faster you say it, the better it's going to come out. Okay, but the transsphenoidal hypophysectomy, or anything that disrupts your intracranial pressure, you better watch for an ADH problem. Okay, let's take that big word, transsphenoidal hypophysectomy, and let's break it down. That is a really good strategy. Anytime you have a big procedure or a big word, you break it down to figure out what in the world does this mean. All right, when I see the word trans in medical terminology, it means going through. Now, sometimes people think across, and there's nothing wrong with that. But I want you to start thinking about going through it. Okay, going all the way through it. All right, when I see sphenoid, sometimes our textbooks say bone. And there is nothing wrong with bone, but I want you to start thinking about a sinus, like a cavity. Okay, so sphenoid is a sinus. This is where people mess up. They look at the next part and they think, oh, hypo. I know what that means. Hypo means below. But it's not hypo. The word is hypophysis. Now, I know if you've never heard of that before, you're like, what? Hypophysis is a fancy way of saying pituitary. Now, guys, don't ask me why they did that. I don't know. Because pituitary should be enough. But we just got to give it another name. Hypophysis. And then the one that we do know. Ectomy. Ectomy means to take something out or to remove. So let's put this together. This is a surgical procedure where they're going to go up through your nose, okay, your sinus, to get to the pituitary gland to remove a portion of it. Got it. That is the reason why I told you to point in between your eyes. Because they're not going to drill a hole in your head. They're going to go up through your nose. All right, this is a great place for us to do a clinical judgment exercise. Okay, now with these clinical judgment exercises, this is where we put you in a weird scenario and we make you use your clinical judgment to get out of that scenario safely. All right, so let's pretend I'm the client. I've been having these really bad sinus headaches. So I go to the doctor, the EENT, and they say, you know what, AG, we got you. You just need a simple sinus surgery and all of your headaches are going to disappear. So I think about it and I decide, you know what, that sounds like a good idea. I'm going to do this. So now I've had my surgery. I'm waking up in the PACU and I'm looking up at you, my brand new nurse. And you look down at me and you say, oh, AG, you did so good. You just need to go in void. Okay, if you go void, you can go home. So I'm like, yeah, okay, I got this. I'm a nurse. I know how to measure my own urine. So I'm going to get up and I'm going to go void. You do not have to help me. I got this. Okay, so I get up and, I'm still a little bit groggy after this surgery, but I got it. I grab the hat. I go into the bathroom and I void. And guys, I come out and I proudly announce to you, hey, brand new nurse, I did it. I got 3,000 milliliters. Question, let me know in the chat or the comments. Are you worried? I did exactly what you told me to do. I voided. You said void, I did. Okay, are you worried? Yes or no? Of course you're worried because you're like, what in the world? What do you mean 3,000? Where is the 3,000? The hat can't hold that much. It's everywhere. It's dripping on the floor. It's dripping down my arm. Okay, well, the NCLEX people are concerned that because you're new, like you've never done this before, instead of being concerned like you're supposed to and worrying about the urinary output, you might say, 3,000. Are you sure? Okay, great, girl. You got some good kidneys. Let's go. And you get me the wheelchair. You put me in it and you start giving me my discharge instructions. And you are so focused on those discharge instructions because you're so scared that you're going to forget something. And you're telling me things like, make sure you take all of your antibiotics, okay? Come back and see your primary healthcare provider in 2 weeks. Yep. And don't forget to get your lab work drawn. Cool. And if you have any problem at all, you call. Okay, bye-bye. And guy, you kick me out. And my husband, non-medical, by the way, takes me home. And people start calling and checking on me. And they're like, how's AG? And he's like, oh, she's good. You know, she was a little bit cold. She was in there shivering. So I covered her up with a blanket. And now she is sleeping so good, I can't even get her to wake up. What did you just send me? What did you send me home to do? D-I? Yeah, you can go ahead and add an E to the end of that. Hey, you sent me home to die. What disease process did I develop from a simple sinus surgery? It was evident by all of that urine at one time. Diabetes insipidus. Remember D and DI, think diuresis? Yeah, I started voiding so much because I've developed diabetes insipidus. And yes, you can go ahead and start thinking about shock. So first things first, do not send me home. Okay, I was not supposed to be discharged. Number 2, have you guys ever heard of DDAVP, also known as desmopressin? That is the medication that you could give me in the meantime for my own ADH to return to normal. That'll help me with some of those signs and symptoms. All right, but please don't let me go home. Now, I know that all of you panicked when I said 3,000. Here's a good strategy. The NCLEX people are not going to give you a number like that. They already know that you would panic if you saw 3,000. They're going to give you a number that sounds okay. So that way you don't, might not think that there's that big of a deal. But this is what you do. Rule. Assume the worst. Okay, please remember that there are no happy NCLEX questions, and there would not be a question if there wasn't something for you to worry about. So you always worry. If they give you one single value, like a urinary output, go ahead right now and know that it's either too much urine or not enough. It's going to be up to you to decide. All right, but there's going to be a problem. There's always a problem in every question. All right, good job. Let's move on. And now let's talk about the signs and symptoms that the client can experience with fluid volume deficit. Okay, so first, their weight is going to go down. Now, let me explain to you why we have it written the way that you see it on your screen. You see weight gain, and then there's an arrow that goes down. That is medical terminology, the way that it is supposed to be on the NCLEX. They might ask you, what happens to the client's weight gain? The weight gain decreases. That's all this is saying. It is not saying that they will gain weight. It is saying the weight gain goes down. All right, then they're going to have a slow or decreased skin turgor. Now on the NCLEX, you might see something that says rapid recoil. That means good. Okay, if I see rapid recoil, that means that the skin turgor is great. But in this situation, the skin turgor is decreased. They're going to have dry mucous membranes. They're also going to have a decreased urinary output. Now guys, I don't want this. I want my client to have good urinary output. But the urinary output is going to decrease for 2 reasons here. Either the kidneys are not being perfused, or they are trying to compensate. And all that means is that they're just trying to hold on to whatever fluid that they have left. Now the blood pressure. The blood pressure is going to go down. Here's a good strategy to help you remember this. The blood pressure is going to go down because there is less volume. And so your strategy is less volume, less pressure. Anything dealing with pressure, if you have less volume, you will automatically have less pressure. All right, that means that I got to watch this client carefully. They're going to need some safety considerations because they're at risk for orthostatic hypotension or postural hypotension. All right, now, the pulse. The pulse is going to go up. And let's think about why this pulse goes up. The body's trying to pump around what little bit of volume you have left. You don't have a lot of volume for good perfusion. So the heart is like, oh, I got to go faster. Let me move faster so I can get this little bit of volume where it's supposed to go. So the pulse increases. And the way that I would describe this pulse is weak and thready. Those are some really good words to describe the way that this pulse feels. All right, when we see the word thready, that just means thin. Okay, thin like a piece of thread. All right, now the next thing we have there is their respirations. Their respirations are going to go up. Now, why is that? Well, your body really can't tell the difference between a lack of volume and a lack of oxygen. So it's basically saying, oh my goodness, you're hypoxic. Let's breathe faster. Okay, so that's the reason why the respirations are going to go up. Okay, the CVP, central venous pressure. Here, remember we said less volume, less pressure. This number is going to go down too because there is less volume to circulate around. All right, now the peripheral veins, they're going to vasoconstrict. And guys, all that means is they get really teeny tiny. So it's going to be hard to start an IV on this client. Okay, that is not going to be easy. And then the one that we all know. When somebody goes into shock, how do their extremities start to feel? How about their skin? Like, what does their skin start to feel? Cool and clammy. We know that one. That is our favorite one. And that is true. We get cool and clammy. Sorry, I've tried to mix those words together. Clammy extremities. Now, when you think about this, yeah, it's important for you to know that that happens, but it's more important for you to understand why it happens. When you start going into shock, do you need your blood out here? No, where do you need it? At your core, right? To perfuse the vital organs. So you're going to get peripheral vasoconstriction in an effort for the blood to shunt to the vital organs. That just is a fancy way of saying it leaves here and it goes here. All right, and then the urine-specific gravity. This is showing you or telling you how concentrated or dilute the client's urine is. So what do you think is going to happen to this number? It's going to go up. Okay, it's going to go up because if the client puts out any urine at all, it's only going to be a little bit. And that means it's going to be concentrated. And concentrated makes numbers go up. Here's your strategy. Concentrated makes numbers go up. Dilute makes numbers go down. Well, with this client, when they're in shock, they don't have a lot of urine to give you. And so if they do, it's going to be just a little bit concentrated. And that would make that volume or that value go up. All right, we're never done till we treat, so let's talk about how we treat fluid volume deficit. The first thing that we need to do is prevent any other losses. Your client does not need to lose anything else. It's going to be very important. Then we're going to replace whatever volume they lost. So if they had like a little simple deficit or a mild deficit, I would need to give them their volume PO. Okay, least invasive first, right? Yeah, and then if they have a severe deficit, then I'm going to give them their volume IV. Because again, least invasive first. Okay, and then safety precautions. Remember, we already said that this client is at a high risk for shock, okay, a high risk for falls. So we're going to make sure that we're checking those vital signs because they could have a fall due to the vital sign changes. And we also need to watch mental status changes because that can cause a fall too. So they are at a high risk. And then watch their IV very carefully because you don't ever want to accidentally overload this client. Anytime you give IV fluids, you always have to watch for chances of overload. All right, guys, great job. Okay, so let's now go into our questions. I'm going to explain how the questions work. We've got 10 NCLEX style questions that we're going to do together today. We're going to put one at a time on your screen and give you some time to think about it. And when you think you know what your answer or answers are, I want you to use your chat and let us know there. Then I'm going to come back on and we'll walk through the question together. All right, so take a peek at question number 1. Let me know what you think about it in the comments or chat, and then I'll be back on to walk through it with you. All right, friends, if you need some more time, you've got it, but let's go ahead and start looking at what in the world is going on with this question. Okay, so first, in the question, I have to read it and figure out what the problem is, because I'm never going to be able to answer the question, fix the issue, if I don't know what the problem is. Okay, so in this one, my client came in 24 hours ago. They've got sepsis. The primary healthcare provider gives us some prescriptions. And then they want to know, what data should we report? Okay, so always first, put yourself in the clinical scenario in whatever role the nurse is in. Okay, because you're the nurse. That can be the charge nurse. That can be the nursing supervisor. That can be the nursing educator. That's you. Okay, so you're the nurse. And they want to know, what do I report? Okay, well, there is something I can use here. One of the rules that I can always use is I only report abnormal data. Okay, I never report anything that's normal. And then this is the dreaded select all that apply. And so guys, there are rules for select all that apply questions. So let's make sure that we understand what the rules are first before we start looking at the options, because this is going to help us. In any select all that apply question, you are going to see select all that apply listed at the end, and it will be bolded, so that way you can see that. There can be up to 10 options. Now, outside of a case study, you'll only get 5 to 6 options to choose from. But inside of a case study, you could get more than that, up to 10. Now, guys, don't panic. Please don't. It does not matter how many options they give you. You treat each option as stand-alone, true versus false. That just means when you look at each option, you determine if it's true or false. If it's true, pick it. False, leave it off. But then when you move on to the next option, please don't think about the option that you just left from. And don't think about the option that's coming after it. You look at each option completely standalone by itself and consider if it's true or false. All right, then make sure you only pick the things that are true, right? Don't pick anything that's false. And what you also have to remember here is that, yes, of course you do get partial credit, but just because you get something right does not mean that they automatically have to give you credit for that. It depends on a multitude of factors. You could get some piece of this question right and get no credit for it. So you want to try your best to get the full question correct, because that will be very helpful for you. All right, now let's go back into this question and figure out what is true, what is false. Remember, I only need to report abnormal data. Okay, but then first I just say, is this abnormal? And then if it's abnormal, does it still need to be reported? Because every now and then you can get something that's out of range, but that doesn't mean that it automatically needs or warrants a call to the primary healthcare provider. So you're going to have to use your clinical judgment. Okay, so let's look at option number 1. When I look over these vital signs, you might be going, okay, well, the blood pressure is a little bit low. Okay, but let's think about what happens in shock. In shock, because that's what sepsis is, remember? This is a type of shock. In shock, the blood pressure drops and the pulse and respirations go up. Do I have a set of baseline vitals to compare this to? No. So I don't know what happened. I don't know if it did drop. When that happens, all I can do is go with what is normal. Even though this blood pressure is on the lower end, it is still good enough. It is still enough pressure for good perfusion. Okay, just because you don't like it doesn't mean that it's abnormal. And then the heart rate, even though it's borderline, it's still within normal limits, and so are the respirations. 20 is a good number. If the client was having a problem, that number would be lower than that. Or higher than that. The respirations will go up. So because I don't have anything to compare this to, I just have to go with what's normal. These are normal vital signs. Even though I might not like the blood pressure, does not make it bad. Hey guys, when do you panic? The blood pressure has to be less than 90/60. Anything less than 90/60 is just not enough perfusion for good pressure. Or not enough pressure for good perfusion. So option number 1 is false. Okay, again, just because I don't like it doesn't mean that there's something wrong with it. All right, move on to option number 2. Okay, well, this is a lab. And anytime you have a lab, they must give you the normal values, okay, the ranges. So when I look at this, it's 110. Let me go over here. The normal reference range says 70 to 90. Okay, well, that means 110 is out of range. Okay, but remember what I said? Just because something is out of range or abnormal does not automatically mean that you call the primary healthcare provider for it. Guys, do you call a primary healthcare provider for a 110 glucose? No, we don't. And there is some evidence in this question as to why the glucose has gone up some. What is the client taking? Do you see the steroid? Yeah, the client is taking a steroid, hydrocortisone. And what do steroids do? They inhibit insulin, making your glucose go up. But even though this is out of range, it is not high enough for me to even think about calling the primary healthcare provider. 110 is not it. So option number 2 is false. All right, move on to option number 3. Now, another lab value. They gave me my normals. And guys, let me tell you something. They typically will not even mention if the client is male or female unless it is in a case study. That means whether they're male or female doesn't matter here. I just look at all the ranges. And guys, 12 and 38 are within range for everybody. It does not matter. It is within range here. So I'm good. Moving on. That one's false too. I don't call for that. Okay, the ABG. With an ABG, any number that is out of range here is a problem. Because if any number is out of range, we have an acid-base imbalance. So that means I don't have to go past the pH. The pH is only 7.3 and it's supposed to be somewhere between 7.35 and 7.45. That's not good. Okay, that is on the lower end, which means acidosis. I don't have to tell them what acid-base imbalance it is. It's just abnormal and I need to call. Option number 4 is true. And then for option number 5, you knew this one. I need urinary output to be at least 30 milliliters per hour. And 25 is just not enough. If you're in shock and your urinary output's going down, that screams an issue. So option number 5 is also true. So for this question, 4 and 5 only are your true statements. All right, do you guys see that in order for you to answer the questions fully right, you have to know content? And then you use strategy on top of that? If you don't know your content first, and I mean when I say no content, I mean the NCLEX way. Not just knowing something. You all know something. You went to nursing school. Of course you know something. I mean knowing it the NCLEX way. Okay, that's why we teach content first. All right, let's move on. Let's look at question number 2 and do the same thing. Look over this one and let me know in the chat or the comments what you think. All right, if you need more time, you've got it. But let's go ahead and start looking at this one. Okay, so when I look at this one, I've got a client with dehydration. They've been getting some IV fluids for the last 4 hours. And they want to know what assessment finding noted by me or you, the nurse, would require notification of the primary healthcare provider. Okay, so again, here we go with notifying. And remember, I only notify for abnormal data. So the first thing that I should do here is get rid of anything that's not abnormal. I can narrow this down very easily. Okay, so the first thing that I'm going to get rid of is option number 1. Remember what we said when we talked about blood pressure? Yeah, if this client has been dehydrated, which means they could go into shock, the blood pressure here is normal. I don't panic until the blood pressure is less than 90/60. If somebody's got a 108/70, that's great. Okay, I don't report that. All right, now that also means the next one that I can get rid of is option number 4. I know 30 is right on the line, but we said people have to give us at least how much? 30 milliliters. And that's 30 milliliters, so I can't report that either. So that means that I can only choose between either option 2 or 3. Okay, so what I do here now is that both of these are abnormal, right? I don't want you to have nausea, And I don't want you to tell me that you feel anxious. Those are abnormal things. So what I have to do now is pick the killer answer. Out of those two answers, which one is going to kill your client? All right, let's talk about both of them. Has anybody ever died from being nauseous? No, except me a few times. I walk around and go, oh my gosh, I'm so nauseous, I'm about to die. Okay, but no, I never actually did die. You might have some nausea when you're dehydrated. Okay, that is normal. In fact, your nausea probably led to vomiting, and your vomiting is probably what caused your dehydration in the first place. So you might have some nausea. Nobody ever died from that. Okay, let's move on to option number 3. What is going on in this stem of the question that may make your client feel anxious? Like something is just not right? Overload. Do you see where they're getting volume? We've been giving them IV fluids, 150 milliliters for the past 4 hours. Couldn't we accidentally be overloading them? Yes. And then when you get overloaded, what happens is you start getting hypoxic because you've gone into a fluid volume excess now. See, when they say that they're anxious, that is that sense of impending doom, and you can't measure that. There's nothing else that's measurable about that. So here's your strategy. Never dismiss a client's concern or complaint. That will always be wrong. So when they look at you and say, I'm feeling anxious, you better panic. That is that sense of impending doom, meaning that my client is starting to get hypoxic. Okay, so if you see restlessness or anxiousness, think hypoxia first. Restlessness or anxiousness, think hypoxia first. And so option number 3 is the one that will do it. That is the one that is correct. And y'all see again, I know my content and then I use strategy. Content and then strategy. All right, let's move on to question number 3. Look over this one and do the same thing. Let me know in the comments or the chat what you think about this one. Okay, if you need a little bit more time for this one, don't worry, you've got it. But let's go ahead and start looking and see what's going on here. I see a bold word. And when you see a bold word, that could be best, like this one is. It could say most. It could say immediately, priority. It could say anything like that. Okay, so when you see any of those bold words, this is what I want you to think. This makes this question very important. And there are 4 options. I can only pick one of these. So I need to pick the one answer that fixes the problem I have. That's the goal. Fix it. Do not gather more information. Do not show the NCLEX people how smart you are. Fix the issue. That's it. Just fix it. Okay, so let's go and figure out what the problem is first so we can fix it. You got a client that came in with an exacerbation of ulcerative colitis and severe dehydration. So again, we're worried about shock. They want to know what is the best indicator that this client has an actual fluid deficit. You're looking for what shows you they're going to go into shock the most. Okay, what shows you shock the most out of the options that they presented you with? All right, so let's look at each of these. And again, I like to get rid of bad answers. Okay, so the first bad answer that I'm going to get rid of is I'm going to get rid of option number 1. Okay? Because, yeah, I hate that you had 10 episodes of diarrhea in a day. I hate that. But guys, how much was in each time? Is there enough information in this to give you enough to pick it? No, because if I could ask the client, I go, well, I don't like that. I don't like 10 episodes. How much was it each time? And they go, oh my gosh, it was so bad. It was this much each time. And I'm like, That's not that much, my friend. Okay, there's not enough information here for me to determine that you actually went into a deficit. I don't like it, but it's just not enough. So that one's out. Okay, well, that also means that 4 is out. Okay, let's talk about it. Yeah, they helped me out better by giving me an INO, which is great. But then they also went and messed it up by saying, plus some diarrhea stools. How much? I don't know. How much was in the diarrhea stools? And how can you be in a deficit if your intake is more than your output? Did you catch that? Yeah, they took in more than they put out. You can't be in a deficit if you took in more than you put out. That's not how that works. So option number 4 is out too. So that means we've narrowed this down between either 2 and 3. And I will tell you, the best indicator, 9 times out of 10, when it comes to determining fluid status or volume status, is a daily weight. Both of these talk about weight. But if you're in a deficit, what should happen to your weight? You remember we said the weight gain decreases, so they lose weight? I got to find the one where they lose weight, and that is going to be option number 3. In option number 2, they gained weight. If you're in a deficit, you do not gain weight. You lose weight. So option number 3 is the only one that works. And guys, this is too much weight lost over a short period of time. Okay, they've lost too much over a very short period of time, 2 days. Okay, so option number 3 is the only one that works here. Okay, again, do you see how that works? You have to know the content first and then use strategy. And I will also remind you, this is a good place to tell you, please don't misread the question. Please make sure you understand what they're actually asking, because if you misread, you're going to get the question wrong. All right, let's move on to question number 4. Do the same thing. Let me know in the chat or comments what you think about this one. All right, if you need more time, you've got it. Okay, but let's look at this one too and figure out what's going on. You see the bold word again? Yeah, very similar question to the one that we answered before, but the bold word says now priority. But that doesn't change anything. Remember what I do with the bold word. I go, this is important. There's only 4 answers to choose from. I can only pick one. So let me pick the one that fixes the problem that I have. All right, so let's go find the problem. The problem is that you've got a client that's had a forearm escharotomy. The only way that you're going to pick the right answer here is you've got to know what an escharotomy is. Okay, an escharotomy is where they go and they remove that dead necrotic tissue, burned tissue from a client's arm or wherever. Okay, so if they are removing this dead necrotic tissue from the client's arm, why did they do that? They did it to enhance perfusion. The whole thing about an escharotomy is to restore circulation, to restore perfusion. Okay, well, if you didn't know that, you wouldn't be able to pick the priority. Okay, well, since I know what it does, is there anything about perfusion here? Yes, option number 4. Okay, so why I have to pick this one is because this was all about perfusion. If you have poor circulation, you're not going to be able to keep your extremity, meaning that this client is at risk for an amputation. We may have to take their arm off, and we don't want to do that. Okay, so why are the other 3 not right? Of course, I'm going to look at all of these things, and I'm going to see if they have any of these things, but you had to pick the most important based off of what they presented you with for this. Okay, so why is number 1 not right? I always look for signs of infection, but it could take you a lot longer to get an infection than it would for you to have poor tissue perfusion. It only takes a few minutes of poor tissue perfusion for you to end up having permanent damage. It could take hours upon days for you to end up developing an infection. And guys, if you don't watch the perfusion, you're not going to have an arm to get an infection in. You see how that works? Yeah. Okay. I always want to notate what the incision looks like. That's definitely important too. But out of the 4 that they gave me, it's not the most important. And then, of course, I always want to see if my client is in pain. And that is probably what the client would say is their priority. But guys, I can't pick pain over tissue perfusion. Because if I just treat their pain, they're going to stop hurting with poor circulation, and they still may need an amputation. So here's the strategy for things like pain. Rule, and this is going to sound horrible, but it works. Pain never killed anybody. People have died from things like poor tissue perfusion. People have died from an infection, but nobody has ever died from pain. Yes, things can happen after the pain or as a result of the pain, but pain directly has never killed anyone. So I can't go with that one. I cannot choose pain over tissue perfusion. Option number 4 is the NCLEX priority answer here. All right, let's move on. Let's look at question number 5. Now, this is an ordered response question, meaning you have to use all of the options and put them in the correct order. So look over this one, choose your order, and then we will come back and talk about it. All right, if you need more time, take it. But in this situation, they just really want to know, hey, brand new nurse, do you know how to place an NG tube? That's all this is asking you. To look at these options that they presented you with, you have to use all of them, but just put them in the right order. That's it. Okay, so when I'm placing an NG tube and I'm looking at these options that they've given me, what has to come first? Okay, well, if you don't measure it first, you don't know exactly how to place it. And so please make sure the first thing you do is the measurement step. Okay, so measure. Then, if I'm your client and you start just trying to put this thing in after you measured it, but you didn't lubricate it first, I'm going to stop you. I'm going to be like, whoa, friend, you didn't lube this. Okay, so make sure that you lubricate it. Now, I want you to think about the fact of why you measure before you lube. If you lubricate it first and then you try to measure, the client's got lube all over their face. Okay, that's just not cool. Let's not do that. Okay, so measure it first, then lubricate it. Okay, then I can't do any of these other steps until I start actually placing the catheter. So I'm going to insert the client's NG tube into their unobstructed nair. So just make sure that you're using the unobstructed nair because you don't want to, accidentally try to put it in the one that's obstructed. It's not going to go anywhere. Okay, so those steps might have been pretty straightforward. Where we start to get a little confused is maybe the next step. Do I rotate or do I advance? Okay, do I rotate or do I advance? Okay, well, let's read both of those fully so we can figure out what's going on. It says, rotate catheter and advance into the nasopharynx. And the other one says, advance NG tube upward and backward until resistance is met. Okay, question. Do you know what the resistance is? Because, when you put in an NG tube, you will meet resistance. That is intentional. It is the entrance into the nasopharynx. Okay, so I've got to get there first and then do something to get past the resistance. So that means that the step that says advance the NG tube upward and backward has to be the next thing that we do. All right? Then, how do I get past the resistance? I'm going to rotate the catheter to get it into the actual nasopharynx. Okay, so just remember, the resistance is the entrance into the nasopharynx. And then to get past it, to get on in there, I have to rotate it. Okay, that's the way that you get past. All right, so then of course that means that I don't want to leave it in the nasopharynx. It's got to get to the stomach. So having the client swallow ice as you continue to advance that NG tube is going to make it go into the stomach. Exactly where it's supposed to go. All right. Okay, so this is your order. Now remember, yes, on the computer, most likely what you would have to do is move these. You drag and drop them into the correct places. But here, where we're writing in these options, that is the correct order that you write. Okay, good job. All right, let's move on, and now let's look at question number 6. Look at this one and let me know in the comments or chat what you think the answer to this one will be. Okay, if you need a little bit more time, you've got it, but let's start looking at this one. This is another select all that apply, and we've already talked about the rules for that, so just make sure that you apply all the rules that you see when you see a select all that apply question. Use those rules. All right, so for this one, you're teaching a client about low platelet count precautions. Okay, guys, do you notice how they did not give you the normal range for platelets here? Yeah, why did they not? Because they did not list a value. There's nothing about the platelet actual count listed here. They will only give you the normals for labs when they mention a number. If they just say low or high, you don't get that. So what does that mean for you? You still better have a general understanding and idea of your lab values and what each thing means. Okay, you can't forget that. You got to have it. All right, so they want to know, you identify that the teaching has been successful, meaning, yes, the client has understood, they got it, when they make which statements. Okay, so look at each of these statements completely alone and ask yourself, does this mean that they understood, or do I need to reinforce teaching? Is there something else I need to tell them here? They are not the expert. You are. So the client doesn't have to tell you everything. They just have to say something that is true. If whatever they say needs a reinforcement, like, no, let's fix this, or if it's completely false, then it can't be right. Okay? All right, so let's look at the first one. What do I worry about when somebody has low platelets? Bleeding. This client could bleed. Okay, so that's the number one thing I'm going to worry about throughout these options. Okay, so when I look at option number 1, the client has done something that scares me. They have placed a limitation on themselves by saying, I just can't do it. I cannot. All right, well, there's a strategy about that. I don't ever let clients place limitations on themselves unless the limitation is absolutely true, absolutely necessary. So when the client looks at you and says, I can't shave until my platelet count is normal, I do not let them walk around thinking that, because that's not true. Yes, even though I'm worried about bleeding, is there some way that they could shave more safely? Yes, an electric razor is what we are taught. Guys, the client didn't even mention that. They just said, I can't do it. So when they say that, you go, no, wait. You can shave. Do you have an electric razor? You're not doing anything for your client by letting them think it's okay to walk around like it's No Shave November, okay? Because that's not true. Option number 1 is false. Don't let them do that. All right? With option number 2, they say it's important for me to gargle with a commercial mouthwash 3 times a day. And I'm going to be like, oh my goodness, you're going to bleed, because commercial mouthwashes typically contain alcohol, and that is drying to the mucosa, especially if you do it 3 times a day. You're going to bleed. So option number 2 is false. They don't understand. That does not show me understanding. All right, option 3, a stool softener should be taken daily. Yes, to prevent the chance of straining and damaging the rectal tissue. Now, that does not say a laxative, okay? If you said you were going to take a laxative every day, we got a problem. But a stool softener is just to prevent straining. So option number 3 sounds like a very good idea. Yes, you should do that. That makes me think you understand. So option 3 is true. All right, look at option number 4. Prior to sexual intercourse, I will use a water-based lubricant. That sounds like you're trying to prevent friction, and friction would cause bleeding. So yes, that sounds like you understand. That is true. Now, sometimes students have a problem with this one for 2 reasons. One, they go, it didn't say if the client was male or female. That doesn't matter. Do you want friction, period? No, I don't care. I don't care if the client's male or female. I don't want friction at all. Use a water-based lubricant. And then the other problem that they have is water-based. That's the only thing you use on sensitive membranes. Please don't use oil-based or anything else petroleum-based. You are supposed to use water-based lubricants on those sensitive tissues. So option number 4 is true. All right, and then the one we knew. Option number 5 was the one that you were like, yes, that one's definitely true. Because you only use a soft bristled toothbrush to prevent damage to the gum tissue. So if I'm worried about the client bleeding, I make sure that the only thing they use is soft. So for this one, 3, 4, 5 are your true statements here. Good. All right, let's move on to question number 7. Look at this question and then let me know in the comments or the chat what you think about this one. All right, if you need a little bit more time, let's look at this one. Okay, but remember what we said, bold words. I got a bold word that says most. I've got 4 answers. I can only pick one. Which one fixes the problem I have? Okay, so they want to know what's the most important information to obtain when a client is admitted with cardiac dysrhythmias. Okay, well, I know that if you have a dysrhythmia, that means that the blood is not perfusing like it should. And so if you have an issue with perfusion, we're going to have a problem. Let's look and find something that would show an issue with perfusion. Okay, an issue with perfusion. Okay, well, that means I'm getting rid of option number 1. Isometric exercises don't have anything to do with that. And guys, this client has a heart problem. I don't want them performing isometric exercises anyway, because that could increase the workload on their heart, causing them to have more of an issue. So I don't want you to do isometric exercises. Please don't. All right? The next one I'm going to get rid of is option number 3. What does blood sugar have to do with perfusion? Not much. All right? If you got a blood sugar change, I'm more worried about diabetes, right? Or insulin, things like that. Okay, and then option number 4, just because you've, eaten a certain amount of fat does not mean anything at all about perfusion. Okay, if you got a dysrhythmia, what does the amount of fat you eat have to do with that? Nothing. I know people that eat low-fat diets that still have issues with dysrhythmias. Eating a low-fat diet does not fix that. Okay, but look at option number 2. If you have a dysrhythmia, and we said that this is going to change your perfusion, you're not going to get good perfusion anywhere. If you've got bad perfusion to your head, your LOC is going to drop. So that would cause you to have a change in your LOC or behavior. Option number 2 is the only answer that works here. They will have a change in their level of consciousness or behavior because that would show an interruption in perfusion. That matches, that fixes the problem that I have. All right, moving on. Let's look at question number 8. Do the same thing. Look over this one and let me know in the comments or the chat what you think the answer to this one will be. All right, if you need more time for this one, take it. Okay, but let's look at this one. Again, there's a bold word, priority. I've got 4 answers. I can only pick one. What is the most important thing here? And it's got to fix the problem that I have. All right. Okay, well, let's go in the question and figure out what in the world is the problem. Okay, what's going on in this one is you got a 6-year-old that's been getting chemo, and their platelet count is 20,000. Then they give you the normal range for that. Okay, remember we said when they give us a number, they have to give us the normal range. Okay, and they want to know what is the priority nursing action. Okay, well, what's the problem? Some of you looked at this and you didn't go past chemo. You were like, chemo's the problem. No, it's not. The platelet count is the problem. And guys, you don't have to have chemo to have a low platelet count. Chemo causes a disruption and a destruction of all your cells. But the main one they wanted you to focus on is platelets. What do you worry about when somebody has low platelets? Bleeding, which means your answer has to match bleeding. Your answer has to match bleeding. All right, I know, right? Okay, so let's go and find the ones that don't match that. All right, look at option number 2. I know, again, when you saw chemo, you just immediately were like, oh, that's got to be infection. But it's not about chemo. It's about platelets. And guys, platelets don't have anything to do with infection. That would be your white blood cell count. They didn't give me that, they gave me platelets, so it can't be option 2. It can't be option 3 because in order for you to have oxygen, I'm worried about your O2 sat. Okay, maybe you're anemic. You got low, H&H. I would need to see something more about that for that. They didn't give me either of those. They gave me platelets. And then for it to be option number 4, again, anemia, you would need to increase that iron intake. I would need a low H&H for that. Ferritin level for that. The cell they gave me is platelets, and I worry about bleeding. The only answer here that's about bleeding is option number 1. What is quiet play? Play where you do not run around, where you're not running around rambunctiously, where you can bump into something and hurt yourself and cause a bruise. Children love to play, and they like to play hard, and that is their work. So I need to encourage quiet play so that way they reduce their chance of bleeding. Option number 1 is the right answer here. All right, let's move on to question number 9. Let's look at this one, do the same thing. This is a select all that apply question though. And then let me know in the comments what you think the answer or answers to this one will be. All right, if you need more time, you've got it, but let's start looking at this one too. Again, select all that apply, so use the rules that we've already talked about. Okay, so in this question, I've got a client on bed rest, and they want to know what interventions should I, the nurse, implement to decrease the risk of complications of immobility. Guys, I can't pick any of these if I don't know what the complications of immobility are in the first place. Hey, do you remember in the first semester of nursing school when your teachers talked about all the bad things that happen to you when you don't move around? That's what you need to answer this question. All right, so let's look at each option as standalone, true versus false. All right, look at option number 1. Provide foods high in calcium. Okay, well, let's think about it. When somebody is on bed rest, what happens to their calcium? It leaves their bone where it's supposed to be, and it goes and hangs out in the blood, making the client hypercalcemic. Because remember, we're judging this from blood work. So if you're already hypercalcemic and then I go and give you some food that has a lot of calcium in it, I'm going to make you even more hypercalcemic, causing you all kinds of problems. Option number 1 is false. In order to keep calcium where it's supposed to be, you have to be up bearing weight. The client's not doing that. So option number 1 is false. All right, move on to option number 2. Place a pillow to float the heels while they're supine. That sounds like a good idea, so that way their heels won't be flat on the bed. If their heels are always on the bed, that puts them at risk for developing a pressure sore or a pressure ulcer on the bottom of their feet. We don't want that. So option number 2 is true. All right, look at 3. When you are on bed rest, you don't have enough volume going through your GI tract, putting you at risk for constipation. I do not want my client to strain when they try to go to the bathroom. So stool softener sounds like a great idea as well. Option number 3 is true. Okay, look at option 4. Intermittent pneumatic compression devices are those devices that blow up and deflate on the legs. This is going to keep the blood in motion in the legs, preventing a DVT. Option number 4 is a true statement as well. All right, move on to option number 5. Incentive spirometer helps to open up the lung fields. The client is at risk for things like pneumonia or atelectasis when they're on bed rest. Incentive spirometry will help to prevent that. Option number 5 is a true statement. All right, and then option number 6, this is helping the client move their legs while they are on bed rest. This will keep the legs and the blood in motion, again, preventing a DVT. Option number 6 is a true statement as well. Guys, there was no way for you to answer this question appropriately if you did not know your content first. All right, so for question number 9, 2 through 6 are all true statements. The only one that's false is option number 1. All right, let's do one more together. Let's look at question number 10 and do the same thing. Let me know in the comments or the chat what you think is going on with this one. All right, guys, if you need more time for this one, please take it. But let's go ahead and start looking at this one. Again, it's another select all that apply. So remember the rules. So let's go and see what's going on with this one. You got a client that's admitted with diagnosis of Addison's disease, and they want to know what nursing interventions should you implement for this client. There's no way for me to choose this if I don't know what's going on with Addison's. That's why we first talk about content. All right, when a client has Addison's disease, they are deficient in all of the steroids. That means they don't have enough glucocorticoids, mineralocorticoids, or sex hormones. All right, one of the main ones that I worry about, though, is the mineralocorticoid, aldosterone. That's the one that's responsible for making you retain sodium and water. Well, if you don't have enough of that, You're going to lose sodium and water, go into a fluid volume deficit, and worry about shock. All right, I'm going to use that now to help me with this question. All right, let's look at option number 1. Administer potassium supplements as ordered. Okay, just because it says as ordered does not mean that I automatically do it. Is there something wrong with giving potassium in this scenario? Yeah. When you have somebody that has Addison's, remember we said they lose sodium and water. If somebody is losing sodium, they're going to have a high potassium because remember those two have an inverse relationship, meaning if one is up, the other is down. So they're already experiencing hyperkalemia. If I go and give them some potassium, I'm going to cause a lethal arrhythmia. Just because it says as ordered does not mean that you do it. Option number 1 is false. Look at option number 2. Assist to select foods high in sodium. Yes, because we just said that their sodium is low. They've been losing it. So they need something to replace the losses. Option number 2 is true. Look at 3. Administer fludrocortisone as ordered. Okay, well, what is fludrocortisone? It's a steroid. And we just said that this client is deficient in all of their steroids. They need more steroid. Option number 3 is true. All right, look at 4. Monitor intake and output. I just said that this client will be in a fluid volume deficit. They will be losing their sodium and water. Anytime you have a client with a volume problem at all, I&O is always correct. So option number 4 is true. And then option number 5, daily weights are an excellent indicator of volume status. So option number 5 is true as well. Now I know I'm not supposed to tie these together, but I will tell you, if you see anything about I&O and then you see something about weight, pick them both. Okay, if it involves fluid, just pick them both because I&O and daily weight are best friends. They always stick together. Okay, so for this question, 2, 3, 4, and 5 are correct. Number 1 is the only one that is incorrect. There is no way for you to get that question right if you do not know your content first. That is why we teach content first and then go into strategy because otherwise you're just guessing. All right, guys, we've got a review for everyone. So you're going to choose the review based on the way that you learn best. So what I want to do is take just a couple of seconds to talk to you about the differences between 2 of our most popular options. We've got Hurst Now, and then we've got our InStream. So with Hurst Now or Now Plus, it is fully online, self-paced, good for the student that needs flexibility in their learning plan. And you're going to choose the length of access that you need, 30, 60, 90, or 120 days. And then you've got InStream. InStream is virtual live. And so for this one, what you're going to do is you're going to have 3 days with the instructor, sort of like what we've been doing together today. And then you also get an online account. So it's really the best of both worlds, where you get live instruction and then you get an online account to go back and rewatch or re-listen to anything that you need to hear again. All right, so we've also got Hurst Elevate, which is the study companion. Hurst Elevate will automatically come with Hurst Now Plus, the 120-day option. But you can add it to any version of the review that you like. So if you want to take InStream and add Elevate, you can. A live in-person review and add Elevate, you can. So it's totally up to you. This is going to make sure that you're studying the right things in the right way. It will also give you additional questions, scenarios, and help you with making sure that you're studying the content in the right way. All right, we love a payment plan. There are going to be payment plans available to each of you, so you can utilize PayPal, Google Pay, or Apple Pay. All of those are active. And, with things like PayPal, you can use those options that allow you to space out your payments over a period of time, up to a year. So that way it makes those payments really small and more digestible for you. What you're in right now is considered to be a free event. So we do want to give you the QR code that you can scan for future events. So if you want to scan that and then just bookmark the website, you can. Please make sure that you're registered for our free events before you come because that will ensure that you have a shot at winning the Q-Bank. We give away a Q-Bank at the end of every session if we have eligible winners. And so we do want to make sure that you guys are eligible for those. You do have to attend the session, but you also have to be registered before you come. All right, and then let's get you guys that discount code. The discount code is good for the rest of the year. So if you use the discount code FREE2025, it will take up to $40 off the review of your choice. Again, because this code is good for the rest of the year, please make sure that you take a picture of this, screenshot this, or just write it down somewhere, because we do not share this code outside of these events. So if you ask us in the DMs, we can't give you this code. Okay, if we have another code that it's available, we will give you that one, but it will not be this code and it will not be the same amount off. So please make sure that you put this code somewhere so that way you can use it whenever you need. All right, we do have an eligible winner for today's or this session's QBank, and the winner is Kiana Kent. Okay, congratulations joining us on Zoom. Kiana Kent, you are the winner of this session's QBank. Now, Kiana, you don't have to do anything at all. We've got your contact information. We will send you an email with your code and instructions, but please make sure that you give us at least 2 business days to get this to you, because it takes us a little while to make sure that we've got the code set up correctly and that it is activated before we send it to you. Also check your spam inbox, because sometimes it goes into the wrong spot. So if you don't have it within 2 business days and it's not in your regular inbox or spam, please reach out to us. We will make sure that you get that. But again, congratulations to you on Zoom, Kiana Kent. All right, guys, that is all we've got for this session, but I'm coming back. If you join me back at 12 Central Time, okay, 12 p.m. Central Standard Time, we're going to do our NCLEX challenge. That is where we're going to look at 3 high-level NCLEX questions. We're going to go over those deeply together. So if you want to practice more questions with me, make sure that you join us again at 12 p.m. Central Standard Time. Same spot, okay, either live on YouTube, or you can catch us through the Zoom link. All right, guys, I hope you have a great rest of your day. Continue to stay safe and save lives, and we'll see you later, again at 12 Central, or if not, we'll see you in the future. Bye-bye.